My name is Talia. I'm really happy to be here, and thank you for organizing this wonderful conference. It is always hard to talk in front of an interdisciplinary audience, and it's especially hard after lunch. So I'm just going to do my best to keep you interested. I'm a student of Professor Weinschel, who gave the 2 previous talks in the last session. And I will be talking about automated facial expression analysis in schizophrenia, taking a continuous dynamic approach. This study is also with collaboration of Professor Abraham Peled and other clinical doctors in the Shar Menashe Mental Hospital. So in the previous session, we saw a lot about the magic of machine learning, how you can take some kind of features, for example, vocal features, facial features, and use it in order to train a classifier and to get some kind of a diagnostic tool. Now, these tools may be one day of great help in clinical settings, but the disadvantage of most of these studies, just like Elena said in her talk, is that the whole learning process is some kind of a black box. So it's really hard to know what the decision was based on. What exactly does this learner do? And what our study tries to do is to, I'm gonna find the right arrows, is to open this box and try to gain some clinical insights from the learning process to learn something about the relation between, in our case, facial expressions and the diagnosis. This is extremely important in the case of psychiatry. Psychiatry, again, as mentioned in the last session, has no objective measure. There's no blood pressure, mental blood pressure that you can take from a patient in order to evaluate their condition and to monitor them over time. So the reliability is pretty low. A second thing is the validity. We can label patients as suffering from depression, from schizophrenia, and so on, but we really know very little about the relation between this label and the underlying brain disturbance. Our study focused on schizophrenia, which is one of the most severe mental disorder with lifetime prevalence of about 1% worldwide. The disease is characterized by negative symptoms, which involve the loss of some function and abilities. This include lack of speech, lack of motivation, and also blunted affect, which is a reduction in facial activity. I'm going to talk a bit more about that later on. Another characteristic is positive symptoms, positive in the meaning of additional. So these are functions that are not present in healthy individuals, including hallucinations, delusions, and so on. Our scale for schizophrenia is traditionally used in clinical setting. It's called the Positive and Negative Symptom Scale for Schizophrenia. It's a 30-item scale for 30 different types of symptoms, including positive, negative, and general symptoms. And each get a score from 1 to 7. Okay, so the objective of our study was to characterize the way schizophrenia is manifested in facial activity. And we also wanted to develop automatic tools for quantitatively describing and analyzing relevant measures of this behavior. So this is the outline. It's very similar to what Professor Weinschel showed. We start by collecting clinical data. Then we compute some facial features. And we use these features first to create some kind of a predictor, some kind of a diagnostic tool that can tell us if someone has schizophrenia or not, and also to evaluate symptom severity. In addition, we try to open the box and gain some clinical insights regarding the relation between these features and the diagnosis. Okay, so I'm going to go over this one by one. We start by collecting the data. We had 34 schizophrenia patients and 33 control subjects. They were all recorded using 3D cameras, Karman, the same technology that was previously demonstrated. Each patient underwent a short clinical interview done by a trained psychiatrist, and they were evaluated for symptom severity using the Positive and Negative Symptom Scale for Schizophrenia. Now, the way we extracted feature out of data is using phase shift, as earlier introduced. So this software gives a lot of facial action units. An action unit is basically the activity of one small muscle-like in the face. From the entire data of that face shift returned, which shows 23 facial action units. I'm going to call them AUs from now on. These were just chosen based on tracking sensitivity and noise level, just to get something that we know that we can count on from the software. And this is the way raw data looked like. We see here one control, one patient, over the entire interview time. Each line represents the one facial action unit, for example, brows up, smile to the left, smile to the right, dimple, and so on. Blue color here is just zero activity, and warmer color represents higher level of activity. So just by looking at this control on this subject, we can clearly see some differences. I've shown this to Avi, my co-instructor, how do you call it? Supervisor, and he says, "Oh, I see blended affect. This is for nature." But of course, these signals are very complicated. It's a time series. We have, for each patient, about 15-minute long interview, which is about 3,000 frames of 23 different action units. And we were looking for a way to represent these in a set of features that we can understand it in the clinical settings. So not just moments, also something that we can say something about it in the clinic. So this is what we do. First, separately for each action unit, we segmented the data using K-mean clustering. So instead of a continuous signal from 1 to 0, we got a number in an integer from 1 to 3. And then we were interested not only on the intensity of the action units or their presence, but also on the way they change over time. So what we did is to calculate a transition matrix. This is a matrix that represents the number of transition between levels of activity. So from 0 to 1, from 1 to 2, from 2 to 3, and we just count the number of these transitions. Now these are the features that we calculated. Again, one for every, all of these for every action unit separately. First, we had some intensity measure, which include the ratio of activation. So this is just basically counting the number of non-zero frames and dividing this by the total number of frames. We also were interested in the level of activity. So the level of activity, just the mean of the activity in the non-zero frames. Now, as to dynamic temporal features, first we just looked at the length of the activity, and then we had some more dynamic measures like change and fast change. Change just means that we looked at that we counted the number of frames where there was a change in activity, divided by the total number of non-zero frames. And fast change is a bit more subtle. It's just taking the jump of more than 1 in activity level. So from 1 to 3, from 0 to 2, and so on. And we just divided this by the total number of change frames. So this gave us a kind of a set of features that can easily be interpreted in a behavioral manner. In addition, we of course calculated some moment features over the entire time, mean, variance, skewness, and kurtosis. And now we use this set of features first to create some kind of a diagnostic tool to predict both patient versus control classification and symptom severity prediction. Learning was done using a two-step learning algorithm based on SVM for classification and ridge regression for symptom severity assessment. Again, we did a leave one out train test paradigm, which means that we took all subjects by one to train the algorithm, and the subject left one was used to test to evaluate their performance. And these are our results. For a patient versus control classification, we got 90% correct classification rate. This is a combined measure of sensitivity and specificity, true positive rate and false positive rate. As for symptom severity, so here the y-axis is the prediction given by the algorithm, and the x-axis is the score given by the psychiatrist. and we got significant correlation. We can see this is just the score for blunted affect, but we got similar results for all the negative symptoms, and even for one of the general symptoms, the poor attention. Right? Yes. As for the positive symptoms, there was no such correlation. This could be explained by the reason that most of our subjects that didn't have a positive correlation, they were most of them under drug effect, which usually reduces most of the positive symptoms while negative symptoms still remain. Okay, so we got a very nice, I think, diagnostic tool, and we wanted to try and gain some insights from this tool. So we opened the box, and this is what we found. First, what we did was to try and do the same learning process, but now we just used a different set of features every time. So the features that I introduced earlier was used for all action units. And what we found is that the features that are most informative for learning are the dynamic features. Just by looking at activation length, we got up to 88% correct classification rate. This means that if I only look at how long does the smile or the brow, a combination of the action unit, how long does it take from onset to offset, I can get a pretty good classification. The second best features were change and fast change. So our results really emphasize, I think, how important it is when we try to analyze facial activity to not only look at the intensity and the presence of the action unit, but also to look how it changes over time, because there's a lot of information there. Another thing we did is to look at each action unit separately and to just compare activation level between patients and controls. So these three on the, let me see if this works. You see it? Okay. So these three action units, smile, dimple, and mouth to the left, they were all found to be significantly reduced in patients, while these three, these are brows up, chin raise, and frowns, were found to be increased in patients. Now, we really try not to emotionally interpret our data. We are just trying to get some more or less physiological measures. But we did try to interpret these results based on some known literature. So we used Ekman, who is a prominent researcher in the field of facial activity and its relation to emotion, and also our intuitions. And what we see here is that these action units are traditionally related to positive, pleasant emotions such as happiness, while these three are related to less positive emotions like sadness, fear, and disgust. Okay. Now the last thing I'm going to present is smile analysis. Smile is one action unit that is pretty easy to interpret in the terms of emotion, how it looks in clinical settings. So we just looked tested how smile looks over all features. And what we found is that though its level is reduced in patients, the length and the fast change ratio in smile is induced in patients. So if I try to imagine what this graph looks like in clinical settings, so you might imagine that patients don't smile less, rather they have less intense smiles, that the duration is longer, and the onset and offset may be quicker. So I will try to demonstrate. Maybe it can look like something like this. Okay, so it's long and it's frozen. It's also known as frozen smiles or fake smiles. So I think this is just an example of how much intuitions and information we can get out of these tools. And there's so many different ways to keep on interpreting the data and get more and more clinical insights. In summary, our results are in excellent agreement with previous studies and with reported clinical observations. We have shown that facial activity has a predictive power for analysis and also for symptom severity assessment in schizophrenia. We also demonstrated how important it is to look at the dynamics of the activity rather than only looking at the intensity. And we saw how we can look at the activity in different facial parts in order to learn something about the emotional value of the facial activity. Just a few reservations that are important to notice. As I said before, most of our patients were under drug treatment, which on one hand means that we're not sure if what we measured was only the severity of the symptoms or also drug effect. And nonetheless, it is interesting, even if it's some of it is due to the fact that they were under treatment. The treatment also caused most of our patients to be type 2 schizophrenia, which are characterized by more negative symptoms. So we didn't really get a chance to test how the positive symptoms, such as delusions and hallucinations, are manifested in facial activity. So we think future work should involve type 1 schizophrenia, who has a lot of more positive symptoms. And we would like to, this is really, really hard to do in clinical setting, but it would be wonderful if we could do such studies on drug-naive patients. Another direction that we would love to go to is big data. We only had 34 patients and 33 controls, which is enough for statistical analysis, but maybe there are some things that some tools that we can't use and some insights that we can't gain from such small data. And of course, as I said before, there are many, many different types of analyses and directions that we can do. If any of you has any suggestions, I would be happy to hear. And I would like to thank Professor Daphna Weinshall and Professor Avraham Peled, my supervisors, and also the good people in Shar Menashe who gave a lot of their heart and their time for this work. And of course, the Good Institute that supported and funded this research. And thank you all for listening.